Hello, good afternoon, everybody. This is Dr. Aishwarya Parthasarathi. I'm a gynecologist and fertility specialist practicing in Chennai. And today I'm going to deal with very, very important topics as far as obstetrics and gynecology is concerned. In fact, this is one of the most common theory questions and practical question that would be asked in the examination, both in the undergraduate and the postgraduate level. Although this presentation is made at a postgraduate level, I would strongly recommend every undergraduate reading for exams also to go through the presentations in toto because it contains a lot of vital information. Apart from it being theoretical, it also contains a lot of practical information, how we can administer iron in practice. So very, very basic things. Anemia is such a common problem and such a relevant problem in the Indian scenario, especially in the setting of pregnancy. If you are a postgraduate in one of the government colleges, definitely there would be almost half your patients, or maybe 80 to 90% of your patients, pregnant patients, would be anemic at some level, and all the spectrum would be seen in the government hospitals. And nothing teaches more than a patient. Nobody can teach you more than a patient. So let us just see what is anemia in pregnancy and how we can administer iron therapy. So anemia is not only a problem with India, it's a very common nutritional disorder in the world. So this is for all over almost 528.7 million women of childbearing age are affected by anemia, and the most common disorder during medical disorder during pregnancy, in fact, is anemia in pregnancy. So when I started the series of medical disorders in pregnancy, I wanted this to be the first because it's very, very relevant, and the global prevalence is almost 38%. 38.2%. So when it's more than 40%, it's considered to be a very severe public health problem. So you can consider how it prevails in India. So almost the percentage of women with hemoglobin of 7 is 1.3, but the percentage of women with HB of less than 11, which is actually anemia, is 54. So it definitely is a very severe public health problem as far as India is concerned in pregnant women. So coming to the definition, how do we define? So when you are asked in the exam, you can always quote a WHO definition. Hemoglobin concentration of less than 11 grams per deciliter and hematocrit of less than 33% in the antenatal period, and hemoglobin of less than 10 gram per deciliter in the postpartum period. See, there is a difference. In the antenatal it's 11, and in the postnatal, obviously because there is going to be a drop, there is a lower cutoff, 10 only, less than 10 is considered to be anemia. So the statistical definition is condition of low circulating hemoglobin in which hemoglobin concentration has fallen below the threshold, lying at 2 standard deviations below the median value for a healthy matched population. And the cutoff point according to the CDC in 1998 is 10.5 in the second trimester and 11 in the first and third trimester, which is the 5th percentile. So the severity of anemia as far as it goes, what do we follow? So many definitions are there. Always go according to this: mild, moderate, severe and very severe. WHO you can always quote wherever you go. Mild is 10 to 11. Moderate is 7 to 9.9. Severe is 4 to 6.9, that is 7, and less than 4 grams per deciliter is considered to be very severe. I have also given a quoting with ICMR 2009 guidelines where there are only 3 categories: mild, moderate and severe, and less than 5 is considered to be severe. But for exam purposes, if you for a definition purpose, most of them would accept to the WHO definition. Now, classification of anemia. It can be a physiological anemia. Say for example, a lady is having a thalassemia trait, obviously they are going to have this one, physiological anemia. However, there is also an acquired anemia, nutritional anemia, that is iron deficiency and megaloblastic anemia of chronic disease, and anemia caused by the blood loss, acquired hemolytic anemia, aplastic or hypoplastic anemia. Iron deficiency anemia is the most common anemia of all these types. Genetics, of course, yes, hemoglobinopathies, thalassemia, sickle cell anemias and other hemoglobinopathies, and hereditary hemolytic anemias are there. These are all just for the theory purpose, you can quote in your exam. RBC membrane defects, spherocytosis, and red cell metabolism defects. Now going on to iron deficiency anemia, which is a very important long question or short question, and in fact a practical examination question also. So this presentation is going to be about iron deficiency and the iron replacement therapies only. Now coming to this. So maternal requirement, we would require a total of 1000 milligrams in pregnancy, out of which 500 milligrams it will go for maternal hemoglobin mass expansion, 300 milligram will go towards fetus and placenta, 200 milligram will be shed through the gut, urine and skin. And in the early pregnancy, the requirement of iron per day is 2.5 milligram per day, and 20 to 32 it increases. That is, in the second trimester it will increase to 4 to 6, and after 32 weeks it becomes even higher, 6 to 8 milligrams per day. So that is why we start supplementing iron at least from 14 weeks onwards. In the lactation also there is a small requirement like in the early pregnancy. So it is a good idea that people will continue the iron supplements even during lactation. And 150 milligram of iron saved because of amenorrhea running through the 10 months, but still you need an 850 milligrams. So this has to be replaced. What are the iron rich food? See, these are basic things. Okay. So usually what we can tell, dry fruits, meat and some green leafy vegetables, figs, dates, all these things contain lot of iron, and the absorption of iron depends upon the amount of iron in the diet, bioavailability of iron and physiological requirements. And iron sources are of two types. One is the heme iron and another is the non-heme iron. Heme iron is actually a very less percentage. Hemoglobin and myoglobin from the red meat, poultry and fish. Absorption is 15 to 30% and it can increase to 50% if not affected by inhibitors. So this is very absorbable kind of iron. But the non-heme iron is more prevalent. Almost 95% of the sources contain non-heme iron, and this is mostly in the vegetables, jaggery, dried fruits, and the absorption is very less. Actually it's only 10% and it can be influenced by all the inhibitors and the enhancers.